Hi everybody, and welcome to our module on dysmenorrhea. Dysmenorrhea refers to painful menstruation, and when women have painful menstruation, we classify it into one of two categories. The first is primary dysmenorrhea, and the second is secondary dysmenorrhea. Primary dysmenorrhea refers to crampy lower abdominal pain that occurs during menses, but if you do testing and a workup and evaluation, there's no identifiable disease that explains the woman's symptoms. So women with primary dysmenorrhea have a normal uterus and fallopian tubes and ovary. If you do imaging, there's no underlying infection or endometriosis. They simply have painful menstrual periods with a normal genitourinary system. And the cause of primary dysmenorrhea is increased uterine prostaglandin production. This causes contractions and pain in the uterus during menses, and that's what leads to dysmenorrhea. And so primary dysmenorrhea is common in primary care practices and also in gynecology. There are lots of potential treatments, but I've listed some of the important ones on this slide. NSAIDs are helpful because they decrease prostaglandin production. Combination oral contraceptive pills improve menstrual pain, and so for women who desire contraception, in addition to relief of dysmenorrhea, this is a very good option. In particular, progestins relax the uterus, so this can help a lot. And even in women who can't take combined oral contraceptives, progestins alone are often used to improve dysmenorrhea. And then besides medications, other things help like heat and exercise and massage. So dysmenorrhea is a common symptom, and many women with dysmenorrhea have primary dysmenorrhea, but a subset has secondary dysmenorrhea. And so how are you going to know which women are in that subset that may have a secondary cause? Well, shown on this slide are some of the historical clues that indicate a woman may have a secondary cause of dysmenorrhea. If a woman has always had mild or normal menstrual periods and then begins having dysmenorrhea at age greater than 25, that suggests that she may have a secondary cause. Also, the pain in primary dysmenorrhea is usually midline. If the pain is non-midline and located to the left or right, that suggests a possible secondary cause. If women have no other menstrual symptoms, in other words, they have pain but no nausea, fatigue, or headache, this suggests a possible secondary cause. Women with primary dysmenorrhea often have crampy pain as well as symptoms like these. If a woman has dysmenorrhea plus abnormal uterine bleeding, which I talk about in another video, that suggests a secondary cause. Dyspareunia, which is painful intercourse, or dyschezia, which is painful defecation, suggests a secondary cause. And then lastly, if the symptoms are getting worse and worse over time, that raises concern for a secondary cause. The list of potential causes of secondary dysmenorrhea is massive, and I won't go through all of them in this video, but I've listed some of the important selected causes of secondary dysmenorrhea on this slide. We'll talk about endometriosis in a minute as well as adenomyosis, but these are both classic causes of secondary dysmenorrhea. Women who have pelvic inflammatory disease, which I talk about in another video, can have painful menses from the infection. Anything that obstructs menstrual flow can cause a backup of tissue in the uterus, and this can lead to dysmenorrhea. So one of the classic causes of this is a uterine fibroid that obstructs menstrual flow. There can also be obstructed flow in women with uterine adhesions or obstructive polyps. And then it's rare, but women can develop stenosis of the cervical canal, especially if they've had prior cervical surgery. And then in any woman with crampy midline abdominal pain, you always have to consider pregnancy, and that always has to be excluded when evaluating any woman for dysmenorrhea. Okay, so now we're going to spend a little time talking about endometriosis, which is a common cause of secondary amenorrhea. Endometriosis refers to the presence of endometrial tissue that is outside the uterus. And women with endometriosis can potentially have endometrial tissue anywhere in the body. There are reports of it occurring in the nose and in the lungs, but there are some common and sort of classic locations that you should know about. So the most common locations are either in the ovaries or in the cul-de-sac, which is the area behind the vagina. Endometriosis can also occur in the broad or uterosacral ligaments, in the uterus and fallopian tubes. It's also common in the sigmoid colon or appendix, and also in the round ligaments. And so the idea here, so that you have a picture in your head, is shown in this image on the screen. So we've got a little bit of endometrial tissue here in the uterus, here's some in the fallopian tubes, here's some on the ovaries. And so this tissue is going to grow and atrophy and bleed with menstrual cycles, just like the normal endometrium. And that's what leads to the symptoms of endometriosis. The pathogenesis of endometriosis, the reason why it occurs, is incompletely understood, but there are several theories. One of the big ones is retrograde flow. This refers to movement of menstrual tissue through the fallopian tubes, where it can travel to the ovaries or the peritoneum and implant, and that leads to endometriosis. There's actually evidence that most women have some retrograde flow, but in most cases, the immune system attacks the tissue and destroys it. In a subset of women, the tissue is able to implant and grow, and that leads to endometriosis. Another theory is metastasis. This is the spread of endometrial tissue through the venous or lymphatic system. And then another theory is metaplasia. This refers to endometrial tissue that arises from coelomic epithelium during development. So this epithelium can be found in many places in the body and undergoes metaplasia and leads to endometrial tissue in an abnormal location. So as I mentioned earlier, the symptoms of endometriosis have to do with the fact that the ectopic tissue is hormone sensitive. So during the menstrual cycle, it will grow from exposure to estrogen, it will atrophy from exposure to progesterone, and there can be withdrawal bleeding at the time of menses. So this is going to lead to growth, bleeding, and inflammation in all those ectopic sites, and that's what leads to symptoms. And so if you understand that, it should be fairly easy to understand that one of the classic symptoms of endometriosis is dysmenorrhea. These women have cyclic menstrual pelvic pain, and that's related to growth and inflammation of those ectopic endometrial sites. Classically, the pain begins 1 to 2 weeks before menses, and it's usually out of proportion to the amount of menstrual bleeding. Another classic symptom is dyspareunia. This is painful intercourse, and this happens because that ectopic inflamed tissue is often found near the vagina, and that makes intercourse painful. And then infertility is also very common in women with endometriosis. This is because the inflammation and the inflammatory changes caused by the ectopic tissue lead to an impairment in fertility. Women with endometriosis can develop dyschezia, which is painful defecation. This happens when there's ectopic endometrial tissue near the rectum. There can also be dysuria, which is painful urination if the ectopic tissue is near the bladder. And then other things to know about endometriosis are that the symptoms improve at menopause and with pregnancy, because in these situations the cycling of the menstrual hormone stops. And you should also know that women with endometriosis have a higher risk of ovarian epithelial cell cancers, and I talk about this in another video. The physical exam in women with endometriosis is often normal, but some of the signs that you can see relate to inflammation at those sites of ectopic tissue. So you could see vaginal tenderness. Some women have cervical motion tenderness. This is usually dull tenderness, not the intense, severe tenderness that you see in women who have pelvic inflammatory disease. You can sometimes feel nodules along the uterosacral ligaments, and you can sometimes palpate an ovarian or adnexal mass. Endometriosis generally does not cause the uterus to become enlarged, so women with this condition should have a normal uterus size unless they have coexisting fibroids or some other disorder. In particular, women with dysmenorrhea who have an enlarged uterus, you should consider adenomyosis, which we'll talk about later in this video. And then in some women with endometriosis, the inflammation and adhesions leads to anatomic distortion of the uterus. So the uterus can sometimes be laterally displaced or retroverted, and this is all related to inflammation and adhesions associated with those ectopic endometrial sites. Imaging is not required for the diagnosis of endometriosis, but it's often helpful because there are imaging findings that support the diagnosis of endometriosis or give you some clues about its severity. The imaging modality that's usually used is pelvic ultrasound, and there are a couple of findings that can potentially be seen in women who have endometriosis. One is the presence of endometriomas, which are cysts around the ovaries. We'll talk about this in a minute. You can also sometimes see nodules associated with endometriosis. And then finally, there's a sign called the sliding sign seen in women with significant endometriosis. To evaluate the sliding sign, pressure is applied with the probe, and the rectum and sigmoid colon should slide across the uterus and the cervix and the vaginal wall. So if there's normal sliding of the rectum and colon, this is called a positive sliding sign, and that's what you expect in normal women. A negative sliding sign means that the pouch of Douglas has been obliterated by adhesions. Basically, if the sigmoid colon and rectum don't slide across the uterus, cervix, and vaginal wall, then that means there are lots of adhesions present from endometriosis. And so a negative sliding sign indicates advanced endometriosis. In terms of diagnosis, you should be aware that endometriosis is often treated empirically based on the woman's symptoms. In other words, a definitive diagnosis is not always known, but the woman has dysmenorrhea, endometriosis is suspected, and it's treated without pursuing a definite diagnosis. If you want to make a definitive diagnosis, you have to biopsy a lesion, and this often requires surgical exploration, either laparoscopy or laparotomy. And if you do this and you find a nodule of tissue and you biopsy it, if the woman has endometriosis, the biopsy will show endometrial tissue like glands and stroma. Another finding you can see at laparoscopy is called a chocolate cyst. This is also called an endometrioma. This is a picture of one on the screen here. The idea behind a chocolate cyst is that the ectopic tissue, if it's found in the ovary, often bleeds, and this can form a hematoma that's surrounded by adhesions. So this will appear to be an ovarian cyst, but then at surgery you will find out that the cyst is caused by endometriosis. And it's called chocolate because it contains a syrupy chocolate-like material related to the bleeding into the tissue. The treatment of endometriosis is a complex topic. There are lots of different treatment options, but I've listed some of the important ones you should know about on this slide. First of all, you should be aware that combination oral contraceptive pills are the first-line therapy. They suppress LH and FSH release, and that decreases ovarian function, and that leads to less cycling of the hormones, and this causes atrophy of the ectopic endometrial tissue. Some women will take the oral contraceptive pills continuously without a placebo period. Women often have a placebo period to cause withdrawal bleeding and menses, but they can skip the placebo period so that they won't get bleeding at those ectopic endometrial sites. Progestin-only therapy is also an option. This is effective in women who can't take estrogens in the combination oral pills. And then non-steroidal anti-inflammatory drugs also improve the symptoms of endometriosis. A newer treatment option for endometriosis that's becoming increasingly popular is the use of drugs that function as GnRH antagonists. The major drug in this class is called elagolix. It goes by the trade name Orlissa. And the idea behind this drug is that it suppresses pituitary LH and FSH production. And so there's less stimulation of the ovaries, and this leads to less estrogen in the body. This is called a hypoestrogenic state. And so there have been a number of clinical trials in recent years of elagolix, and they've shown significant improvement in endometriosis-related pain in women who take this drug. Now you may know that there are a group of drugs called GnRH agonists, which also decrease LH and FSH production. But the problem with GnRH agonists is they take a few weeks to work. In contrast, elagolix is effective immediately and leads to very rapid benefit in women who have endometriosis-related pain. The major side effects are side effects related to low estrogen, the type of things you can see in women who have menopause. This includes things like hot flashes and night sweats. There are surgical options for surgical removal of endometrial tissue. This is usually done only in refractory cases, and it's usually done laparoscopically. Women referred for surgery have often failed medical therapy, and so when a woman is failing medical therapy, there are a couple advantages to referring her for surgery. First of all, you can establish a definitive diagnosis by biopsying a lesion. You can also rule out other pathology, and then you can potentially remove the endometrial tissue to improve her symptoms. After surgery, women are usually placed on progesterone unless they desire to become pregnant. Often it's a levonorgestrel IUD, and the idea here is that you remove as much tissue as you can at surgery, and then the progesterone suppresses residual disease. And so this combination of surgical removal and a post-surgery progesterone IUD often improves women who have severe refractory endometriosis. Drugs that are GnRH agonists, like leuprolide and neferilin, are sometimes used in women who have endometriosis. These drugs are second-line therapy. The idea is they bind to GnRH receptors in the pituitary, and this leads to downregulation of those receptors. Basically, the pituitary becomes desensitized to GnRH, and as a result, it releases less LH and FSH. And so as the release of these hormones from the pituitary declines, the woman will develop amenorrhea and endometrial atrophy, which is beneficial for all those ectopic sites of endometrial tissue. The side effects of these drugs are that they essentially induce menopause because they shut down pituitary release of gonadotropins. So sometimes when these drugs are given for endometriosis, the woman is also given low dosages of estrogens or progestins, and the idea is to minimize the hot flashes and menopausal symptoms caused by the GnRH agonists. Okay, moving on, next let's talk about adenomyosis. In adenomyosis, endometrial tissue like glands and stroma grow into the myometrium. When this happens, this is going to enlarge the uterus, either diffusely or segmentally, depending on how much adenomyosis is present. If you look at this image on the screen, this can give you an idea of what this looks like. You have little bits of endometrial tissue that are growing within the myometrium. Classically, this leads to a uterus that is described as globular or boggy on exam. This is just a way of describing an enlarged uterus from that endometrial tissue within the myometrium. Women who have adenomyosis have menorrhagia, which is heavy menstrual bleeding, and they also have dysmenorrhea. When there is bleeding into the myometrium contracts just like it does when it's trying to expel the placenta after pregnancy. and this leads to cramping and pain and dysmenorrhea. And many women who have adenomyosis also have endometriosis. In both conditions, there's endometrial tissue in places where it should not normally be. Adenomyosis is suspected in a woman who has symptoms like heavy menstrual bleeding and dysmenorrhea and an enlarged uterus on physical exam. The best first test is a transvaginal ultrasound, although an alternative is an MRI, and MRI is excellent for diagnosing this condition. Either of these studies can potentially show abnormal thickening of the myometrium, as well as other findings that indicate adenomyosis. And this is an MRI shown on the screen here. This area that's thickened in the back of the uterus is a segmental area of adenomyosis. This is easy to identify by MRI. The definitive diagnosis for adenomyosis is hysterectomy. However, if the woman is in her childbearing years and wants to have more children, it can be treated with progestins. This is usually done through insertion of a levonorgestrel IUD, which generates local progestin activity, and progestins relax uterine muscle and decrease contractions, so this will usually improve menstrual bleeding and dysmenorrhea associated with adenomyosis. And then when the woman reaches a period of time when she wants to conceive, the progestins can be discontinued. And then besides progestins, there are other medical therapies that can be used in women who want to avoid a hysterectomy. Drugs like GnRH agonists, SERMs, and NSAIDs have all been used to treat adenomyosis. Uterine artery embolization is also sometimes used. This is a procedure I talk about in the video on fibroids because it's often used to treat fibroids, but it can sometimes be used to treat adenomyosis. I'll finish this video with this one slide on the workup for dysmenorrhea. So in actual practice, the workup of dysmenorrhea is complex and there are lots of things you have to consider. But what I've shown you on this slide is a simplified version of how the workup often proceeds, just so you can have an idea in your mind of what is done and why. So when a woman presents with dysmenorrhea, the workup begins with a history and physical exam. She should get a pregnancy test. She should have a screen for STDs like chlamydia and gonorrhea that can cause pelvic inflammatory disease. And then in many cases an ultrasound is done because this can identify thickening of the endometrium or fibroids or causes like that. If the exam is entirely normal, you don't have to do an ultrasound, but one is often ordered. Now if this initial workup is normal and shows benign findings, then usually the woman is treated with either combined oral contraceptives or progestins or NSAIDs. And the idea here is that these are all treatments for primary dysmenorrhea and also endometriosis, so you're targeting some of the very common causes of dysmenorrhea, and with these treatments many women improve. If, however, there's no improvement, then that's when more advanced imaging studies are done. Pelvic imaging is often done, like an ultrasound if one wasn't ordered already, or an MRI. This imaging can identify fibroids and adenomyosis and things like that. A hysteroscopy is often done. This can identify uterine polyps and adhesions. And then you also have to consider that the woman could have a possible chronic pelvic pain syndrome. So once again, this is a simplified version of the workup for dysmenorrhea. It comes from the American Family Physician, and it just gives you an idea of how the workup often proceeds. And that concludes our module on dysmenorrhea.